You do have to press that continue thing. It's a new thing it's doing.
Hit what?
You're good. I think you already did it. Hello, everybody, and welcome to today's webinar. My name is Sabrina McCarley, and I am very excited to be moderating NARA's webinar today, Thinking Outside the Box, Fall Prevention and Screening Refocused with Beth Payne. Before I turn it over to Beth, I would like to cover a few housekeeping items. First is that everybody is on mute. If you are having any technical questions or problems, if you could please type that into the chat. Christy is monitoring that and she will be able to assist you. If you have any questions for Beth, we ask that you type those into the Q&A and we will address those at the end of today's presentation. Beth also is making this very interactive for all of you, so it should be a very great webinar. We are recording today's webinar and the webinar recording will be available within 48 hours. With the recording, we will also be sending out the handouts. So with that, Beth, I am going to turn it over to you.
Thank you, Sabrina. Hello, everyone. Thank you so much for having me today. For about 5 years, I have been soaking up all of NARA's resources and networking opportunities. So it's great to be able to give back. So today we're going to think outside the box and look at things with a refocused perspective when it comes to screening and preventing falls. None of this is going to be groundbreaking research. And we already know some of the solutions, but when we take a step back and actually look at what we're doing, what we know should be done does not always equate to what we're doing. So we're going to identify some solutions to improve patient care during this time when we're expected to do more with less. So a little bit about me. My name is Beth Payne and I'm an OT, and I think I'm biased, but because we're all therapists, I think you're at a high risk of falling for me. But just kidding. Today, we're not going to do the most conventional webinar. I figured that COVID flipped everything upside down, and so all of our standard norms of formatting slides and things like that are out the window as well. Some of you might be in a busy healthcare environment. Some of you might be sitting at home. Either way, I know that there are many distractions and it's easy to disengage. I do not have the most commanding voice, and so there are going to be a lot of poll questions. I live in Northern Virginia, just outside DC, and I have 2 girls ages 7 and 10. So my 10-year-old told me to picture everybody in their underwear, but since many of you probably are at home, you may be or you may not be. But lastly, I love exploring nature, traveling, and I recently started Pilates. So today we're gonna just go through about 30 to 45 minutes of stuff. With the poll questions, I ask that you pay attention, answer promptly so that we can hopefully have more time for discussion at the end, or I can give you some time back in your day. So sit up straight and let's get started. So today what we're going to do is review staffing, discuss screening forms and processes, and discuss some solutions for clinicians to be more effective with their evals, treatments, and discharge planning. What we are not going to do is regurgitate data or debate which assessment is best. 2 years ago, Christy Sheets and I were talking about doing a fall prevention webinar. And when we were originally talking about it, it was going to be largely regulatory focused and legislative focused because the Senate Committee on Aging was having hearings on fall prevention for aging adults and things like that. But again, things have changed. And since we're more in survival and triage mode, we're going to be focusing more on how we can be efficient with what we have. And so let's get started with our first of 4 poll questions. So poll question number 1, what is your role within the company? You all know who I am, so now I want to know who you are. All right, we'll give you just about 3 more seconds. Oh gosh, more people coming in. That's great. All right, so I think we have a large majority of you are corporate leadership. So that really helps so that we can kind of change the discussion to fit that a little bit more. All right, if you could add one element to your existing fall prevention program, what would it be? Would it be more staff, whether it's CNAs, LPNs, nurses? Would it be more staff training, whether it's fall risk assessments, post-fall interventions, things like that? Would it be more equipment, just walkers, wheelchairs, low beds? Or would it be a better fall risk assessment and communication identification system, whether it's a sign on the doorway to signal to people, who is at the highest risk of falling, or different colored socks, things like that. So I'll give you guys just a couple more seconds to get those answers in. All right. So as you can see, it's kind of split, but about equal with more staff training and better fall risk assessment and communication identification system. So I'm a bit surprised that there weren't more people saying more staff, just because I know a lot of nursing homes are lacking that right now. I didn't add the question in here of what setting are you in? So, so we'll try to make sure that we can address that as well. The third question is, what is your biggest challenge with staffing? Is it a lack of staffing? Is it that your staff are burned out and you're tired, not willing and able to do anything above and beyond? Is it a lack of training? Have they not been oriented properly? Are they not understanding how, clicking into, their documentation system fits into the bigger picture of the role for patient care? Or is it something else? I'll give you guys just another second or 2 here. I figured we'd just go ahead and address the elephant in the room with staffing, but hopefully a picture with a cute baby elephant makes it a little bit easier. All right. So it's kind of split. There's a lack of staffing, and then the staff who you do have are burnt out, tired, and not motivated. So, I don't think any of us are surprised by that, but I do think it is good for us to discuss it, to see that we're not alone. And the last question for right now is, we all have acknowledged that we're short-staffed. So in what areas is your workplace short-staffed in? Is it administration, whether it's, the administrator, MBS, director of nursing, social services? Is it nursing, whether it's RNs, LPNs, CNAs, therapy, housekeeping, maintenance, dietary, or is it all of the above? Give you guys just 5 more seconds. All right. So I think it's a little bit of everything, but I think predominantly nursing and therapy, we're all seeing those same trends, but oftentimes we're hearing about administrators who are doing, meal prep and passing trays and emptying trash cans and things like that. Um, we're all in this together, and it is not just contained to our poll. Let's see. So according to a recent survey by the American Healthcare Association of almost 1,200 nursing homes, more than half of the nursing homes are limiting new admissions due to staff shortages. And nearly every nursing home of those almost 1,200 is asking staff to work overtime or extra shifts. And the unfortunate news is it's getting worse, not better. So let's try to look at some outside the box staffing solutions that we may be able to implement. So therapists could actually work as a nursing assistant, not a certified nursing assistant, but as a nursing assistant as the regulations allow, both for the state, federal, and the discipline-specific scope of practice, both for therapy and for the nursing assistant regulations. But it's a win-win-win. So for the facility, this allows for an increase in those admissions and a higher census, or at the very least, it allows you to maintain the census that you do have. For therapists, it equals work. In that poll, not everyone is short-staffed for a therapist. And I think that we've seen, after RUGs and the transition to PDPM, there are still therapists out there who are wanting and willing to work. For some of the programs where we've done this with, the administrators actually said, we'd rather pay you guys and your therapists who know the residents, who know the facility, rather than paying an agency staff where they don't know, and you're kind of, it's working with an agency staff where they don't know anything and they just try to jump right in and do their best. And so for patients, this equates to better care. We have skilled professionals who are able to provide, a non-skilled service, but it still continues to allow those residents to get those services that they need, especially at a time where they've been largely isolated in COVID. We can also provide the RNA services. So not only does this help the patients maintain their functional levels, but for some of those PDPM payers and specific case mix groups, it can increase the reimbursement. And so at a time when we're seeing nursing homes give a $100 stipend to a CNA for filling in an extra shift, us contributing to achieving those case mix groups and capturing that RNA can mean the difference between not being able to have the staff or being able to continue providing those higher wages or stipends to continue with the census. And then we can help with the Walk to Dine and other programs that are largely unskilled, but again, can still benefit the patient to get them up and moving. We still have to consider our quality measures and rehospitalizations and things like that. So as much as we can help with keeping those patients moving, even if it's not a traditionally skilled thing, then it can work. And so we've been doing this. We're a contract therapy company. I've also talked with some of our clients who also have in-house. They're doing it as well. We're doing it differently, yet it's still working. So I think this would probably be the biggest question and opportunity for us to discuss at the end. So whether you want to wait till the end or start putting things in the chat, what are you guys coming up with? Because this isn't going to get any better. It's only going to get worse. And so if we have an opportunity to jump in and help, let's share, let's collaborate and help those patients. All right, so let's move into a little bit more traditional way that therapists can help those residents. And up here, you see those pictures. I was able to break out of COVID quarantine this summer and go on a 9-week, almost 12,000-mile road trip. So Although most of it was for work, as you can see, I visited Glacier, Zion, and Yellowstone, and had some fun exploring national parks as well. But going back to the work part, almost every single facility that I went to, screening came up, whether administrators were saying that we were doing it wrong or not doing it all, or therapy was complaining that it was taking way too long. It was a challenge. And so I want to go into the next few poll questions. We all know the canned answer. We all know what the policy and procedure and what it should be. But I really would highly encourage you to think about, if you don't know the answer, then say, I don't know, because I was largely surprised when I went and found out. So Christy, am I able to get the poll back? I don't know how to do that. Oh, thank you. Okay, so screens. So how often are screens actually being completed? We know the canned answer, but really think about how often are they actually being completed? Is it quarterly, monthly, only as requested, never, or I don't know? And how long should it take, or how long does it actually take you or a therapist to do a screen? Does it take an hour? Does it take 30 minutes, 15, 5, or I don't know? And then the third question is the screen form comprehensive to encompass the entire individual, or does it simply just focus on limited information like decreased range of motion, or simply state just a decline in function? So I'll give you guys just another minute. Okay, so I'm going to share these results now. So how often are screens being completed? It looks like the majority is only as requested. So I don't know if that was since COVID or since before COVID. It looks like it's actually taking about 15 minutes to do a screen, which is great. But as you can see, there are some outliers of the 1 hour, 30 minutes, or 5 minutes. And then is the screen form comprehensive? Oh, somehow those got jumbled up. Anyways, don't worry about that. We will get to that in just a minute. All right, so let's go through some screening for success solutions. The purpose of a screen is to determine a person's appropriateness for rehab. It should be informal, it should be quick, anywhere from 30 seconds to 15 minutes, and it should be hands-off. It should also be comprehensive. So sometimes, and when I was doing the site visits, some of the facilities only wanted range of motion, and that's all therapists were doing because the facility only wanted range of motion. They were doing the bare minimum. They were not looking at the patient as a whole. And so that's something that we've addressed to make sure that we're not only continuing to fulfill the facility's request, but we're continuing to encourage the therapist to think outside the box and address that whole person. There were also some times where the administrator was expecting the screen to be an evaluation and wanted an assessment. And so there may be some opportunities where you have to educate, the facility in terms of what a screen is. So a screen's not an evaluation, and an evaluation does not guarantee that a plan of care is going to be established. They don't require physician's orders, but they do need to be documented in the medical record so that people know it's been done. All right, so whether we've said it ourselves or we've probably all heard it, but there is a myth that patients are independent and that there is no skilled need. So whether you're screening or you're discharge planning, we need to remember that the SNF environment or your healthcare clinic environment creates a false sense of independence. It has good lighting, nice, wide, flat hallways with minimal distraction. So we're not going to go through all of these, but I just wanted you to have them as a reference in case you or any of the therapists are ever getting stuck. I would highly recommend that people don't break down or simulate these tasks. There is no better way to assess how a patient is doing and if they're truly independent by doing the full entirety activity in and of itself. So basically, if you're getting stuck or therapists are stuck, just get into the real world, really learn about what they need to do when they get back home, and try to make our goals and plan of care reflect that. The next one is supervision. I know a lot of times therapists might use supervision as a catch-all because we want a person to be able to walk by themselves to the bathroom, but we don't want the liability if they do fall to be on us. And so we use supervision a lot upon discharge. And I always challenge it back with, did you provide appropriate supervision to the person who is going to be supervising them? Whether it's, a caregiver, a family member, has that been documented and provided? And especially with all of our technology these days and the visitation requirements with COVID, we may have to get a little creative, but I know we've done home evals on Skype and Zoom and FaceTime and things like that. So it certainly can be done, but just really be careful of that word supervision because it can be a safety net for therapists in the facility. But it can also, we just have to be careful that if they truly are supervision, that they are safe to go home, so that they aren't more likely to fall and be rehospitalized. And then there's also a myth that somebody is dependent, so there's no skilled need. So I know that the dependent patients are probably our least likely fall risk category, but I still thought it was important because, especially, again, we can't say it enough, we know that our patients are not receiving all the services that they were prior to COVID. So they've been largely isolated. And so we really need to make sure that we're taking a look at them. We're recognizing that they've lost some functional abilities, and that just because they're dependent does not mean that they don't have skilled needs. And I think you all know Linda Riccio from NARA and Transitional Care Management. She has some fantastic slides on activity needs if you all are interested and kind of stuck with what to do with some of those lower level dependent patients. So I want to go through an eval only scenario, and the reason for referral was that staff recently reported that a patient was out of bed, was developing contractures, and thankfully there was no skin breakdown. So that's all great. Unfortunately, the OT said that the patient is not appropriate for skilled OT services and would benefit from restorative. The problem was there was no restorative program established. So we dropped the ball on that. And although it's a nursing program, I think we can all agree that largely it's the therapist who will set people up on a restorative nursing program. So my personal solution was I became licensed as an OT in that state. And I said, if you're going to do an eval only, then you're going to do it with me on the phone, and we're going to both make sure that that person cannot further benefit from our services. That may not be the solution for everybody. And so I don't have the answer or really great guidelines. I'm not a fan of eval onlys because our patients and their medical acuity and so many of the variations that they have, not only from day to day, but different times of day, and the variations of nursing staff between shift to shift and weekends and weekdays. I really like to, at the very least, put a patient on therapy for a trial basis so that you can make sure that you're hitting those different times of day, shifts, and caregivers. But in the instances where an eval only is warranted, really make sure that it is justified in the documentation. And I think we've all either said it or probably heard therapists say, but I could lose my license. So the canned answer is, we know we need to work within the regulations. Myself and you all are not going to ask anybody to do anything unethical or illegal, but I usually challenge back with, you're not utilizing your full scope of practice. And as an OT, I'll pull out that OT practice framework and I'll say, this is the scope of your practice. This is what you're expected to do. Just because you're not comfortable with it does not mean that you're not expected to do it. And so we really want therapists to practice at their top of the license, and it may mean getting out of their comfort zone. Our patients who are at the fall risk don't fit into that nice square box of textbook patients that some therapists only want to treat. And so we kind of have to help them understand that there are patients outside of that can benefit from their services and require their services, but it is up to us as leaders sometimes to help coach those therapists so that they can practice at the top of their license. All right, moving right along. So some of the solutions, now that we've come up with some solutions for staffing and screening and evaluations, let's talk about treatment planning. And basically, therapists, we are all required to, we get to treat the patients and we have to document, right? Those are two things that we pretty much have to do. So I would encourage therapists to make the most of the treatment time and their required documentation. So that means no cookie cutter goals or plan of care. I know we all get stuck in a rut, but if you can go and do an audit of one therapist and there are variations between the discharge destination or the diagnoses and all the goals are the same or similar, that person is in a rut. We need to reassess often, and we have to make sure that the goals and the plan of care are patient-oriented, function-oriented, and discharge-oriented, regardless of the discharge setting. So another thing I hear, and I'm sure you all may hear it as well, is, well, they're discharging to assisted living, so they don't need to do stairs. Or they're discharging to assisted living, so they don't need to do bathing. They're going to do it for them. So I'll call the assisted living facility and they say, no, they have to do stairs because of our regulations in case of an emergency, and they chose not to pay for bathing as a service, and because it's an additional fee, so they need to do it. So those are some of the things for discharge planning where therapists can really have a huge impact, not only on outcomes, but on fall prevention. If we can really get to know what their discharge setting is, then we can better help prepare them. Also, if residents are staying within the skilled nursing facility or nursing home, that's equally important, and that's a lot where caregiver competency can come in. So I have a plan of care scenario here. There was a 91-year-old female admitted to the hospital due to a GI bleed. She was Mod-I prior to the admission, and the plan was to discharge home with her son. Upon eval, she was set up with a front wheel walker to walk 50 feet with 2 turns, so she was doing pretty well. 2 weeks after the start of care, the patient had functional decline with her O2 sats going down into the 70s when she was ambulating up to 100 feet. And the physician immediately discharged PT due to the decreased oxygen saturations while ambulating. So what do you think is the best course of action? Where did that poll go? Christy, are you able to get that back? Where did I put it? If not, that's all right. Oh, there it is. Thank you, Christy. So do you guys think that we should discharge PT and or OT? Put them on a medical hold for PT and or OT until further notice? Or reassess, reevaluate, and update the therapy plan of care for PT and or OT? And I know we're getting long in there, but you guys gotta stay engaged. We'll get out of here even faster. So put those poll question or answers in there and we'll get you on your way shortly. All right, I'll give you just one more second. Okay, so it's unanimous. Everyone agrees that we should reassess. So whether that's your response or because you saw the next slide, that's the correct answer. So what happened is the physician discharged the patient from PT services, and the patient fell twice over the weekend because nursing had given them a wheelchair and they weren't locking their brakes. The patient was trying to get out of the wheelchair and fell twice. So this is where therapy has the opportunity to advocate and educate the physician on our scope of practice. We could have updated the plan of care to include new goals for wheelchair management and safety. We could have added goals for a perceived level of exertion with transfers or ambulation. You know, this is the patient. Was she feeling symptomatic with her O2 sats in the 70s? I don't know. We can monitor the vitals and activities, and the physician can give us parameters to say, hey, if they're going below 84%, I don't want them walking. And so that's something we can work with. We can also focus on pursed lip breathing, energy conservation with our ADLs, and then that family caregiver training for discharge planning. That patient and son were determined to go home. But as we know, sometimes things change. So we really need that son to be involved so he can see what is going on with his mom, to know that maybe a discharge home is not going to be the most appropriate, or she's not going to be able to return home at the level she was prior to. All right, poll number 9. When do most falls happen at your facility or for your patients if you're not in a skilled nursing facility? Do they happen at night? Do they happen when they're walking to the bathroom without assistance? Do they happen during the day, or do they happen when they're with therapy? And while you guys are answering, I think we all know this lady on the right. We all have one. She's feeling cute. She might try to fall on you when you look away for a half a second. IDK, I don't know. But we know those patients. You have the gait belt, you're watching them and you look away and they start to go down. So you guys are doing great. Keep those poll questions. We're doing awesome and we're almost at the end. Like I said, we only have 10 questions, so we're almost there. All right, so a mixed bag, but the majority say when walking to the bathroom without assist. Go look at your OT's documentation. How many of the goals include walking to the bathroom or going to the bathroom from the bed to the toilet? Oftentimes it is just compartmentalized to a toilet transfer or toileting. And if you think of it, the entire session and all of the goals could be related from going from the bed to the bathroom and back safely. So we all know that's when falls are happening, but really take a look and see, is that what your therapists are doing with the plan of care that they've established and the time that they have with those patients? We have to share our tips and tricks with nursing. We have to help them out. We know them, and fall prevention doesn't just happen in a bubble. We have to remember that these aren't just therapy's goals on paper. They go beyond that. And so we have a responsibility to make sure that we're training not only the CNAs and nurses on our day shift that we work well with, but also we have a responsibility to help the nurses on the night shift. Often when many falls are happening, excuse me, and that we're sharing that information of, excuse me, giving a patient a bedside commode. A lot of times we'll see a therapist walk into a room with a walker, walk them to the bathroom, bring them back to bed, and then leave the room with the walker. That doesn't help nursing. We have to remember that fall prevention is not just with our therapy interventions and treatment. We are only staffed there primarily 5 to 7 days a week during the day. And when we're caring for patients who are requiring 24-hour help, we have to make sure that we're collaborating, with those other departments, disciplines, and shifts. All right, our last poll is, what is a more common physical therapy goal that you write or see? Patient will ambulate 100 feet. Let's see here. Oops. Let me do that again. Or patient will safely ambulate 50 feet. Min assist using a front wheel walker on level and uneven surfaces under high attention demand situations without medical complications in order to prepare for discharge home. So I'll give you guys a minute, but you can see this gentleman here on the right. He has his front wheel walker. He's walking a dog on the sidewalk. So there are so many things that us therapists start seeing in this picture. Why is he using a walker? Is his right hand stronger? Is that the side that he should be holding the dog on the leash with? Is that the best side? Did this gentleman, return home? I know we have home health, and home health, those therapists are amazing, but we really need to think about what that person's life is going to look like when they get home, and we need to write goals like that. So the bottom answer, the patient will safely ambulate 50 feet, that was a build goal in the EMR that we use. So there was nothing that came from my brain in there. I basically went to the gate and built that. I know there are different components in there, and there are a lot of measurable components, but really those are kind of the goals that we need to be writing, because we know with all the managed care, once they see that somebody can walk 50 feet or 100 feet with Min Assist, they discharge them, they're out of there. And therapists go, but we need so much, they still need so much work. And so if we can make the distance less and the amount of things that have to go into that distance more complicated, then we may be able to keep those patients a little bit longer, provide more treatment, and continue providing the care. So as you can see, most people are writing short, sweet, simple goals, and that is common, but that doesn't mean that that's what should happen. We all know that. We need to get back to basics. We know that falls don't occur when a person is walking down a nice, wide, flat, straight hallway with minimal distractions. Go look at the documentation. This is something we're doing internally as well. We kind of got distracted with COVID and everything else. And then we started looking at, the falls, and we went, oh my gosh, we need to bring it back to basics. We need to re-educate the therapists. So if we know that that's not when falls happen, why are we writing goals that still allow for that to be what the goal is? We know that falls don't occur from poor upper body strength. Core strength is more important. So why do we see so many upper body strength goals, and why do we allow it? So we need to get back to the basics of incorporating functional assessments and functional goals to address that root cause. If we can be more comprehensive in our assessments and education and training, and it's not just to the patient, it's to their family, it's to the caregivers. We need to be looking at their vision. Low light scenarios, they're falling at night when they're going to the bathroom. or changes in lighting. All of a sudden, it's disorienting when you're in a dark room and you flip on the bathroom light switch. People can lose their balance that way. We need to be testing those things and assessing those things. We need to look at the sensation, especially in their feet. And obviously the footwear. Were they wearing non-slip socks when they fell? Were they wearing shoes, things like that? Their proprioception, their vestibular system, core strength, their appropriate adaptive device. We know that therapists, like I said, might go bring equipment in and take it out. But even if we're trialing them with a cane or something like that, if we can leave the walker in there, that could really help nursing for all those many 23 other hours of the day that we're not seeing that patient. Surface changes. When they go home, they're going to use that walker and go from, carpet over a threshold to a linoleum bathroom. So we have to test those things as well. And then, of course, teaching people to fall and how to get up after a fall. And I can't emphasize this enough, but we need to practice the activity in its entirety, not just components or not simulated, but we have to get back to doing the entirety of the activity with our patients. That's how we learn best, not to mention that's how our older residents who have, medical diagnoses and comorbidities and difficulty learning and possibly cognitive impairments, they need to learn it from start to finish and not simulate it as well. So the takeaway for today, you already have the skills, but you want to consider rearranging how you use them to maximize the effectiveness of your screening and your fall prevention processes. We all know that, we all know that there are staff shortages. And so if those solutions don't work, that's okay. Maybe this can just be a catalyst for us to start talking with our teams, with our clients, with others to see what they're doing. We already have a screen process, but is it actually achieving what we want it to achieve? So I think that we can all get a lot of bang for our buck with making sure that the screens are being done the way that you want them done to ensure we're providing the care to those residents to prevent falls. And then just maximizing the time. If we already have to do an eval and the treatment, then let's just make sure that we're proud of the documentation that we put forth and that we would be comfortable and confident with receiving that documentation if we were the patient or one of our loved ones was the patient as well. So I want you to just metaphorically rearrange your room and literally rearrange the room so that we can maximize the safety, reduce the hazards, and improve our fall prevention screening processes and reduce the risk of falls. So that is all I have. Thank you all so much for your time.
Thank you, Beth. That was great. I really loved the interaction with the polls. As a reminder for everybody, if you have questions, please type those questions into the Q&A and we will get those answered for you. I know the first question, Beth, this has come up quite a bit, and you did touch upon it, was with the therapist or the therapy practitioners working as nursing aides. I love how you talked about the benefits of therapy and knowing the patients versus having, contracted CNAs, et cetera, come in. What are some of your suggestions, though, that sometimes the therapist will be working with patients that they're not familiar with? So how would you incorporate perhaps a therapy screen in that activity, because this is residents that maybe we haven't had our eyes on, or maybe have slipped through the cracks, as we say, or we're just not familiar with, or a new set of eyes on a patient that maybe it's the rehab director who always does the screen and it's the CODA that's working as the nursing aide right now?
I think that there's so many options. I think switching it up, a fresh set of eyes, a new perspective. Like I said, I got licensed in a different state. And I basically said, if you're going to do an eval only, you have to do it with me present to truly justify it. But I think that sometimes we do have a tendency to get stuck in our own rut or to just say, oh, so-and-so is a frequent faller. And so that's where we really just need to go back to those basics and dig into our toolbox, bring out those assessments. Like I said, I didn't want to get into which one is best, but we all know them. Tug, Nettie, Berg, best test, mini best test, brief mini best test, or whatever it may be. And to have multiple sets of eyes, just as many of us are doing multiple BIMs sometimes, to try to capture that cognitive impairment we know exists. Having another therapist screen, again, as regulations allow. Some states do not allow assistants to provide screens. So you have to make sure that you are working within your regulations. But once you know them, have at it, go take a look at those patients and just try to look at things from a different angle. And if you're stuck, then really go back to doing things in the real world or go back to our standardized tests, which can help kind of guide us.
I think that's a really good point. I think, we've all kind of gotten into this routine, as you said, right? And so refocusing on fall prevention. I know another question that came in was in regards to really the whole toileting aspect. I know that's something that I feel like as an OT myself, I feel like it gains traction and then we lose it and then it gains and then there's falls and it's kind of like this whirlwind, seesaw sort of thing for us in our profession. And so what are some recommendations that you might have as some states, with Medicaid and the reimbursement, now they're focusing on GG too. So kind of getting therapists to really fully think about GG and specifically toileting. I know I was excited about toileting being a part of GG. So what are some kind of tips that you might have as we're talking about refocusing on, fall prevention, but toileting and how that actually can make an impact, not just with outcomes, but financially as well, the overall picture for the facility?
Yeah, I mean, GG we know is impacting nursing reimbursement, therapy reimbursement, case mix indexes. I mean, it's a huge focus, and the incontinence is one of the main reasons that people go to a nursing home to begin with. So that's not going away. And again, I would challenge it. We all know what it should be. And I think that the transition from rugs to PDPM and then with COVID, treatment times may have been reduced. And so I'm encouraging everybody, again, don't just simulate the task. Don't just do the wheelchair transfer to the toilet and just focus on toileting. Do the entirety of, bed mobility, supine to sit, rolling, transfer, that mobility to the bathroom, transfer back to the toilet. And maybe it's just me, but I'm sometimes surprised. I read great documentation sometimes and talk to the therapist and I go, so can you tell me more about this? And they can't tell you because they never did toileting. And then I go, man, you did great documentation, but clearly your treatments were not good. And so that's where it's just kind of coming back to educating and empowering the therapist to really understand the bigger picture of it. And then they in turn can also work with, CNAs and the MDS coordinator to be like, hey, I won't bother you. I know you're, entering in your documentation on the, what is it, POC for point click care or whatever nursing homes commonly use. But sometimes the CNAs are just rope clicking things, and there's no thought into it. And so that's where just those little moments and being like, can you explain why you're doing this? And they go, I don't know, I just have to put stuff in there. And I went, oh my gosh. And so then a door opened and an opportunity to say, well, hey, I have to do toileting too, but you know, I needed max assist times two. They're not independent. And so just starting that dialogue and really getting back to those basics, reevaluating, and actually performing the activity. So if you guys are auditing documentation, that's great. And if it's outstanding documentation, that's wonderful, but I would still question, were those treatments done in the entirety or were they simulated? Because I think sometimes we found, people take shortcuts. So, so just get back out there, start asking questions, not punitively, but really start educating people to say, here's why it matters, and here it does impact reimbursement, and that's how this helps. And it's not about money mongering, it's about continuing to keep the doors open to provide care to those residents. I think a lot of therapists and nurses have a misunderstanding that there's a ton of money to be made in the nursing home industry. And I think those of us on this side, it's a delicate conversation, but we see the numbers, and that's not always the case. So
I think we can also bring it back to, I know we many of us have laughed when Gigi had this picking up small items from the floor, such as a spoon. So the joke was, dietary in the kitchen's going to get upset because we've stolen all the spoons, but they're, bringing back to that. There's a lot of just that fall recovery component that, to your point, are we simulating something? Are we really addressing how do you pick up that small object from the floor? And then how do you tie that back to fall prevention, fall recovery? And to your point, training the nursing staff. Now, that doesn't mean go out and steal all the spoons from, the kitchen, which I fully was anticipating someone to complain about at some point. But the importance and kind of bringing it back to Gigi's not going away. And how do we tie that? And, like you said, tie it into your OT practice framework, et cetera. So the other question that has come in, I will remind everybody, we did record today's session, the copy of the handout, which will include the links to the article that Beth talked about at the beginning of the presentation. That is included in the handouts or the slides. So a copy of the handouts as well as the recording will be sent out to all those that registered within about 24 to 48 hours of today's presentation. It will also be available on NARA's member portal. So with that, I would like to thank you, Beth. This was great. Hopefully it inspired everybody to get refocused on a very important topic that does impact all of us if we're therapists or if we are any member of the interdisciplinary team, especially our patients. So thank you, Beth, and thank you, everybody. Have a great afternoon.
Bye.